Hello everyone, here we are going to discuss a ultra important topic, that is chronic myeloid leukemia CML. So in your university exam, you very frequently get a long question on that. You have to write everything about it, starting from the pathogenesis, classification, clinical feature, lab diagnosis, treatment and prognosis. So we will discuss everything about it. CML, chronic myeloid leukemia, also known as CML. So let's start it. Now in our syllabus, there are four types of leukemias, that is CML, AML, ALL and CLL. So on all of them, there are four separate videos. I request all my dear students to watch the four videos in single shot. I don't know which one you are watching it right now, but whatever you are watching, in whatever sequence you are watching, you should watch all of them in a single shot so that you will have a better understanding. And I request all the students to take out your notebook and take out your pen and start filling this comparative table with me while watching the four videos only. You should fill this table so that at the end you can revise all the leukemias at one place in one shot very easily. So if you have the hard copy of the book, the table is given to you, you just take out your hard copy of the book and you can start filling this table. Okay, so let's start it. So here I am going to discuss the CML. Under a fixed set of headings, we will be discussing all the leukemias. So first I will let you know the introduction, then age, then pathogenesis, classification, clinical features, lab diagnosis, treatment and prognosis. Under these headings only, we are going to discuss all the four types of leukemia. Currently we are discussing CML. So let's start with CML. Let's start with the introduction and age of CML. So what is the introduction of CML? So in the introduction, you have to write down the definition. The definition of the CML: any human being, any adult human being who is having these four things, we can say the person is having CML. What are the four criteria of classifying the CML? Number one, the WBCs are more. The WBCs are more than normal in the blood. What is the normal range of WBC? The normal range of WBC is 4,000 to 11,000. So here the person, instead of 11,000, the WBCs are more than 1 lakh, maybe 1 lakh, 2 lakh, 3 lakh. So there is high degree of leukocytosis. That is, WBCs are extremely high, but most of them are immature one, which are coming in the blood, not the mature one. The second is basophilia. Normal basophil count is 1 to 6% in the blood. Normal basophil is less than 1% in the blood. There are hardly any basophils present in the blood. So, but here the basophil will be more in the blood, more than 100 per mm cube. Splenomegaly, the person is having spleen enlarged, and the Philadelphia chromosome will be present on the cytogenetics. So these are the four criteria to classify any human being having CML. What are the four criteria? Number one, WBCs are high in number. That is leukocytosis, but most of them are immature one, which are coming in the blood. They are in lakhs, 1 lakh, 2 lakh, 3 lakh maybe, instead of 4,000 to 11,000. Number one. Number two, the person is having basophilia. The basophils, among them basophils are more enlarged, more increased in number. Number three, the patient is having splenomegaly. The spleen is enlarged. Number three. And number four, Philadelphia chromosome is present in the cytogenetics. What is Philadelphia chromosome? I will let you know. First, learn the four things present in the definition of the CML. So any human being having these four things, I will say the person is having CML. The age, it usually occurs in old age. Please learn the age. It's specific. It's more than 50 years. Now coming on the pathogenesis. In the pathogenesis, I guess everyone have watched the general video of leukemia and lymphoma classification, definition and classification. If you have not watched, I request you, I advise you to watch that video first so that you will have a basic understanding of leukemia and lymphoma. Then you should watch these all videos, the various types of leukemias and lymphomas. So I guess if you have watched that video, you know how the WBCs are synthesized in the bone marrow. In the bone marrow, you can see the precursors of the neutrophil and the precursors of the lymphocytes are in front of you. You can see the precursors of the neutrophils are myeloblast, promyelocyte, myelocyte, metamyelocyte and band form. And the precursors of the lymphocyte is lymphoblast, pro-lymphocyte and lymphocyte. I guess you can understand this. Now normally the mature forms come in the blood. The neutrophil and the lymphocyte come in the blood. The immature do not come in the blood. But whenever the immature blasts are coming in the blood, that is myeloblast and lymphoblast are coming in the blood, it's leukemia. Currently I am teaching you CML, chronic myeloid leukemia. So here myeloblast is coming in the blood. So basically myeloblast precursors, the myeloid precursors are coming in the blood. I'm teaching you CML. It's a myeloid leukemia. In myeloid leukemia, the myeloid precursors come in the blood. So instead of mature neutrophil, the precursors are coming in the blood here. So all the precursors, which precursors? The 5 precursors. Which 5 precursors? Can you tell me the name? So myeloblast, promyelocyte, myelocyte, metamyelocyte, band form. So these all cells. Now these all are the cells. So let me draw the cells. In these cells, mutations are taking place. Due to physical, chemical or biological agents, mutations are taking place. So all these 5 cells do uncontrolled mitosis. Which 5 cells? Can you say again? The myeloid precursors. The precursors of the neutrophil. Which 5 cells can you enumerate? So it's myeloblast, promyelocyte, myelocyte, metamyelocyte, and band form. These 5 cells have mutations in them. They are doing uncontrolled mitosis. That's why they will replace everything else. And these 5 cells will move to the blood. So in the blood, we are getting 5 cells. Which 5 cells? Myeloblast, promyelocyte, myelocyte, metamyelocyte, and band form. We are getting these 5 cells in the blood, and that is CML. In CML. So what is the name of that mutation which is occurring here? So I'm saying here mutation is occurring in these 5 cells. But which mutation? Which mutation? Now, how many chromosomes are present in human? I guess everyone know the humans have 46 chromosomes. Rather than saying 46, I always prefer to say 23 pairs of chromosomes are present in human. So this is pair number 1, pair number 2, pair number 3, pair number 4. Likewise, total 23 pairs are there. I'm not interested in all 23 pairs. No. I'm interested only in 2 pairs. Pair number 9 and pair number 22. So let me draw the pair number 9 here. And pair number 22. We all have these pairs. I am having, you are having. On pair number 9, we all have a gene. The name of that gene is ABL. It is present in adult human beings, healthy human beings, in me, you, everyone. It is doing its normal function. So whenever the growth factor is present, then only it is doing the mitosis. Otherwise, it's not doing the mitosis. On 22, we have another gene. The name of that gene is BCR. We all have it. Again, it's doing its normal function. Whenever the growth factor is coming, it is doing mitosis. Otherwise, mitosis it is not doing. The mitosis is under control. Now, whenever mutation occurs. So in the mutation, basically the translocation is taking place. What do you mean by translocation? So a portion of 9 is given to 22. In exchange of that, a portion of 22 is given to 9. It's a balanced translocation. So 9 is giving this portion to 22. 9 is giving this portion to 22. That is the portion which contains ABL gene. So ABL gene is transmitted to 22. On 22, there was already BCR. So ABL also transmitted there. BCR was already there, but ABL also transmitted. So basically on 22, a new gene is formed, which is known as fusion gene or hybrid gene. Fusion or hybrid gene is there. That is ABL-BCR fusion or hybrid gene. That is deadly, because individual of them were causing controlled mitosis, but this fusion and hybrid gene, it will form an abnormal tyrosine kinase enzyme. That will do uncontrolled mitosis, and because of the uncontrolled mitosis, it will lead to cancer. Uncontrolled mitosis, it will lead to CML. So this cell will replace all other cells. Which cell is this, by the way? So out of these cells, this cell can be anything. Out of the 5 cells, the same thing is happening in any of the 5 cells. So I mean to say this cell can be this cell, the shown you in the image. It can be a myeloblast, it can be a promyelocyte, it can be a myelocyte, it can be a metamyelocyte, it can be a band form. So in any of these 5 cells, this cell can be. Now in all these 5 cells, the same thing is happening. In all these 5, the 922 translocation is happening. So because of the 922 translocation, a portion of 9 is given to 22. That is ABL is transmitted to 22. On 22, there was already BCR. So ABL-BCR hybrid or fusion gene is formed, that is leading to uncontrolled tyrosine abnormal tyrosine kinase, that is leading to uncontrolled mitosis, that is leading to cancer. So in exchange of this, when 9 is giving this to 22, what 22 is giving to 9? 22 is giving to 9 a portion which don't contain any important gene. So this translocation is known as balanced translocation, and it is happening in any of these 5 cells. So these 5 cells, all these 5 cells are doing uncontrolled mitosis. Since they do uncontrolled mitosis, they replace all other cells. And that is the CML. So what is the pathogenesis? The pathogenesis is 922 translocation. So you can write down 9 and you can write down a semicolon 22. In the small brackets, we have to write down the name of the number of the 2 chromosomes. And we have to write down a small t. That means translocation between 9 and 22, a balanced translocation. Instead of writing the number of the chromosome, you can write the name of the gene. The name of the gene is ABL-BCR. ABL-BCR translocation, because here ABL is present on 9, BCR present on 22. It is translocation, or it is getting the hybridization, so, or fusion. So that is the thing. So among this, you can see the hybrid gene is formed on 22. So the ABL, which is normally present on 9, is transmitted to 22. 22 already have the BCR. ABL is also coming. So ABL-BCR hybrid gene is formed on 22. That's why chromosome number 22 is known as Philadelphia chromosome. So what is Philadelphia chromosome here? The Philadelphia chromosome is chromosome number 22, not chromosome number 9. Chromosome number 22 is Philadelphia chromosome. So basically between 9 and 22, translocation is taking place, which is known as ABL-BCR translocation, because of which Philadelphia chromosome is formed, and that leads to uncontrolled mitosis. Where does this translocation take place? You can see the bone marrow. In the bone marrow, you can see these 5 cells. I mean the precursors present in the myeloid series. That is myeloblast, promyelocyte, myelocyte, metamyelocyte, and band form. In all these 5, 922 translocation takes place. In all these 5, the ABL-BCR hybrid gene is formed. In all these 5, the abnormal tyrosine kinase is formed. That's why all these 5 are doing uncontrolled mitosis. And since they are doing uncontrolled mitosis, they become too high in their number and they are spitted in the blood. So in the blood of CML, you will get 5 things. You will get myeloblast, promyelocyte, myelocyte, metamyelocyte, and band form. Along with the mature versions, which are very few, neutrophil, eosinophil, basophil are there, but very less than number. Maximum are the immature forms. So if you see the count of WBC in the blood, it's very high. Maybe it is in lakhs. So it is very high. Normal count is 4,000 to 11,000. Here they are more than 11,000. Maybe in 1 lakh, 2 lakh, 3 lakh, like that. So this is the pathogenesis. I hope everyone got it. How to write in your exam? First write normal. So ABL gene is present on 9 and BCR is present on 22. Can you see the same? See normal. Don't see the translocation. See normal. This is normal and this is translocation. So I want you to first appreciate the normal. This is normal. And this is translocation. Appreciate the normal. Can you see ABL present on 9? Can you see BCR present on 22? Now I want you to appreciate the pair of 9 and pair of 22. Appreciate the pair of 9 and pair of 22. This is pair of 9. This is pair of 22. On pair of 9, you can see ABL. On pair of 22, you can see BCR. So 9 present on ABL present on 9 and BCR present on 22. Now during translocation, ABL which is present on 9 normally, it get translocated to 22. On 22 we already have BCR, so ABL fuses with BCR, and because of the fusion a hybrid gene is formed, and that is known as Philadelphia chromosome. The hybrid gene size is 210 kilodalton. You have to learn the size. That leads to formation of abnormal tyrosine kinase, and that leads to uncontrolled mitosis, and that leads to CML. So the same thing is shown here in the diagram. You can see ABL which is present on 9. This one is translocated to 22. Appreciate. On the 22, I want you to appreciate the fusion. On the 22, there is fusion. That is Philadelphia chromosome. And instead of that, the 22 is giving a portion out to 9, which is not containing any important gene. So you have to show the translocation. You have to draw this diagram in your exam. So in your exam, I want you to draw this. Draw pair of 9. Draw pair of 22. Write down 9 here. Write down 22 here. On 9, show ABL. On 22, show BCR, normally like this. This is ABL, label it. This is BCR, label it. And this is normal. Now draw another diagram, or in this diagram only, you have to show the ABL is translocated to 22, ABL from 9. So on 22, the fusion gene is formed, which is known as ABL BCR fusion gene. This gene is known as ABL BCR fusion gene or hybrid gene. Instead of that, a portion is given from 22 to 9 which don't contain any important gene. Label it as balanced translocation, and that leads to abnormal tyrosine kinase, and that leads to uncontrolled mitosis. This is happening in the 5 cells. Which 5 cells I told you. So please understand the pathogenesis. Now coming on the phases of the CML. How many phases are present in CML? There are 3 phases. Chronic phase, accelerated phase, blast phase. You can learn a mnemonic CAB, C-A-B, CAB. So C for chronic phase, A for accelerated phase, and B for blast phase, C-A-B, CAB. So I told you now all these cells are coming. Which 5 cells are coming in the blood? You have to learn the name of the 5 cells. Myeloblast, promyelocyte, myelocyte, metamyelocyte, and band form. Because 922 translocation is taking place in these 5. These 5 are doing uncontrolled mitosis. All these 5 are shifted to the blood. The most important among them is myeloblast. So tell me the percentage of the myeloblast which is coming in the blood. If the myeloblasts are less than 10%, it's chronic phase. If it is 10 to 20%, it's accelerated phase, and more than 20%, it's blast. So the myeloblast is coming in the blood, but what's the percentage? Less than 10%, or 10 to 20%, or more than 20%. Less than 10 is chronic, 10 to 20 is accelerated, and more than 20 is blast. So that decides the phase. So phase depends on the myeloblast percentage. Although 5 cells are coming in the blood, I agree. All 5 are doing uncontrolled mitosis, I agree. All 5. These 5 are doing uncontrolled mitosis, but the most important is myeloblast. So after coming in the blood, what is the percentage of myeloblast? Is it less than 10%, 10 to 20%, or more than 20%? That decides the phase, chronic, accelerated, or blast. So please learn that. After that, coming on the clinical features. I told you in the bone marrow, from the hematopoietic stem cells, RBC, platelet, and WBC, they all are formed. I hope you have watched my video on the leukemias and lymphomas definition and classification, the basic video. I guess you know how the blood cells are formed in the bone marrow. Now I'm saying that the myeloblasts are doing uncontrolled mitosis. So myeloblasts will replace the RBCs as well as platelet. So patient have anemia because RBCs are less formed. So patient have pallor, lethargy, dyspnea. Patient have less platelet. The platelet are also less because they are replaced by the myeloblasts. So patient have bleeding disorders like spontaneous bruise, petechiae, bleeding from various organs like the gum, nose, ear, and patient have more WBC. WBC although very high, instead of 4,000 to 11,000, here WBC are 1 lakh to 2 lakh. So WBC are the army. They protect us from the infection. So you may be thinking, ma'am, patient will have less infection because WBC are more. No. You are wrong. I agree that WBC are more, but they are the mature one. They are not the mature neutrophil. No, they are the precursors of the neutrophil. The myeloblast, promyelocyte, metamyelocyte, band form. These are coming in the blood. The premature one. So here, although the WBC count is high, still the patient is at having high susceptibility of infection. So you know this paradox. Although the WBC count is high, still patient is highly susceptible for the infections. So patient have anemia because here the myeloblasts are doing uncontrolled mitosis and they are replacing all other cells. So RBCs are less, platelet are less. RBC less means patient have anemia. Platelets are less, patient have thrombocytopenia. So if patient have anemia, the lethargy, fatigue is there. If thrombocytopenia is there, patient have fatigue, bleeding, and the susceptibility of infection is being more, although the patient is having high WBC count. Now, so many cells are present in the blood. They all are precursors of the neutrophil. So that's why body have hypermetabolism. Continuously dividing uncontrolled mitosis is there in the bone marrow. So patient have weight loss, sweating, anorexia, and splenomegaly is there. Splenomegaly is massive. So whatever cells which are abundant present in the blood, all they will be trapped in the spleen. So in the marrow, the WBC precursors are showing uncontrolled mitosis. The myeloblast series, myeloblast, promyelocyte, myelocyte, metamyelocyte, and band form. These are showing uncontrolled mitosis because of 922 translocation. They all shifted in the blood. That's why patient have features of hypermetabolism. After coming in the blood, their count in the blood is too high. They all are immature. Now they will be trapped in the spleen, so patient have splenomegaly. So please understand the reason. So first, due to bone marrow failure, patient have the three things: anemia, bleeding disorder, and infection. Patient have hypermetabolism and splenomegaly. These are the clinical features. After that, coming on the lab diagnosis. Now I have a fixed protocol for the lab diagnosis. You watch my all 4 videos on leukemias back to back. I request you to watch it in a short in continuity back to back. You will notice that in all 4 leukemias, I have discussed the lab diagnosis under this protocol only, under these headings only. So blood picture, bone marrow picture, cytogenetics, cytochemistry, and others to make a uniformity so that you will have a better retention. So please, whenever lab diagnosis of any of the leukemia, the 4 leukemia, AML, CML, ALL, CLL, any of them is asked in your exam, write them in this headings only. So in the blood picture, comment on hemoglobin, platelet, and WBC. In the bone marrow, comment on cellularity, myeloid cell, erythropoiesis, megakaryopoiesis. In the cytogenetics, tell me the exact mutation. In the cytochemistry, tell me the special strain and others. So let's start with the blood picture. In the blood picture, of course, patient have anemia. Of course, patient have thrombocytopenia. RBCs are less, platelet are less, but WBC are too high. Usually they are 2 lakh. Normal count, never forget, it is 4,000 to 11,000. Here they are more than 2 lakh, oh my God, but they are immature. Show them in the blood. Show them. So in the blood, how many WBCs you can see? I can see a eosinophil having red granules. I can see a basophil having blue granules. I can see neutrophil, one neutrophil. These are the mature one, and I can see multiple premature. So some of them are myeloblast, promyelocyte, myelocyte, band form. So multiple precursors are present. So you have to draw this diagram in your exam. In your exam, you have to draw this diagram. In this diagram, you have to show few eosinophil, you have to show few basophil, you have to show few neutrophil. After that, you have to show many precursors form. Draw few promyelocyte, few band form, few metamyelocyte. You have to draw many precursors. So this is many type of cells you are getting. You are getting promyelocyte, myelocyte, metamyelocyte, band form, neutrophil, eosinophil, basophil. You are getting many type of cells. So basically, I told you here, these 5 cells are doing uncontrolled mitosis. These 5 cells. Which 5 cells? Myeloblast, promyelocyte, myelocyte, metamyelocyte, and band form. These are doing uncontrolled mitosis, and after that, they are coming in the blood. So in the blood, you are getting all 5. So you have to draw this diagram. This is typically known as garden party appearance. What do you mean by garden party appearance? In a garden party, everyone is in different dress. Everyone is in beautiful different dress. So here also you can see many type of cells. Every cell is unique. You can see some cells are promyelocytes, some are myelocytes, some are metamyelocytes, some are band form, some are neutrophils, some are eosinophils, some are basophil. So multiple cells like a garden party. So remember, typical garden party. So if I want to draw this in my exam, in my university exam, I will draw a box in which I will draw the cells. So first I will draw a neutrophil, only one neutrophil I will draw. One I will draw eosinophil, bilobed nucleus, here multi-lobe lobe nucleus, here bilobe nucleus, and I will draw a basophil. I will draw the granules in them, here the pink granules, here the red granules, here the blue granules. I will label them neutrophil, eosinophil, and specifically basophil. You can draw basophils 2, 3 also. Apart from that, I will draw many other cells like promyelocyte, myelocyte, band form. Band form is always drawn like this. The band form is always C-shaped. So this is band form. I will draw few band form. I will draw few myeloblast, few myelocyte, few metamyelocyte like this. I will label. Labeling is important. So I will label this as band form. This one is myelocyte. This one is metamyelocyte. This one is myeloblast because it is having high NC ratio. So I will label them like this. Now I will label the complete appearance as garden party appearance. Garden party appearance, and this is CML. So that is the complete diagram. Now please compare. I'm going to teach you, as I told you, 4 types of leukemia. Now currently I'm teaching you the first one here. I request you to watch 4 videos together so you will have a better understanding. In the CML you can see the garden party appearance. Appreciate all type of cells. Now after this, watch the video of AML and ALL. Just after this you will get here school uniform appearance. All the cells are same. Here also school uniform. In uniform everyone is same in the school. Here also school uniform appearance. You can see all the cells are same. But in CML it's garden party appearance. I told you, no? Garden party appearance. So different type of cells. You get 7 to 8 type of cells there. So that is garden party appearance, not school uniform. In contrast to AML and AL. So that is the thing. So we are done with the blood picture. The hemoglobin is less. The platelet is less. But WBC are too high. They are usually more than 2 lakh. And here they are immature, and you have to draw the diagram also, the garden party appearance. Now coming on the bone marrow picture. In the bone marrow, you have to comment on 4 things. The cellularity in the bone marrow is high because these cells are doing uncontrolled mitosis. So they replace all other cells. So cellularity is very high. Usually most of the cells you will get myeloid cells because only myeloid precursors are doing uncontrolled mitosis. But the erythroid and megakaryocyte, that is RBC precursor and platelet precursor, are less because they are replaced by the myeloid precursor. So myeloid precursors are high, but erythroid precursors and the megakaryocyte precursors are reduced. But myeloid precursors are very high. You have to write like this, and cellularity is very high. So here cellularity is high, myeloid precursors are high, but erythroid and megakaryocyte precursors are low. You have to understand it. Here hemoglobin is less, platelet is less, but WBC are too high, but they are immature and garden party. So you have to draw the diagram of the garden party. Now coming on cytogenetics. In cytogenetics, we take out the cell from the bone marrow or the blood, and genetically we see the mutation. So here if you do the cytogenetics, you will get the Philadelphia Chromosome. That is 922 translocation, that is ABL BCR translocation. So you will get the fusion gene on chromosome number 22, but that is very costly. It is very costly, but it is a confirmatory diagnosis, cytogenetics. So after cytogenetics, we are coming on cytochemistry. In the cytochemistry, we will do a special stain. The name of the special stain is NAP score. NAP, neutrophil alkaline phosphatase, also known as leukocyte alkaline phosphatase. So NAP or lab score we will do. NAP score or lab score. We will do NAP or lab score. So here coming on the NAP or the lab score. Now you know the complete series. There are 2 differentials. When the WBC count are more in the blood, either CML or leukemioid reaction. I assume you have watched my video on leukemioid reaction. If not, please watch that. In leukemioid reaction also WBC are high in the blood, but it's not leukemia. So basically in leukemioid reaction, the mature neutrophil is high in the blood in leukemioid reaction, but in CML, the immature one are high in the blood. So that makes a difference. Here in CML, the immature one are high, but in leukemioid reaction, the mature one is high. Now, in the mature neutrophil, in the cytoplasm, in the granules, there is a component which is known as neutrophil alkaline phosphatase, or also known as leukocyte alkaline phosphatase. The meaning is the same. Either you say NAP or you say LAP. Neutrophil alkaline phosphatase or leukocyte alkaline phosphatase. It is present in the mature one. So you tell me, where does it will raise? In leukemioid reaction or in CML? So I told you in leukemioid reaction, the mature one are more. That's why NAP score is more. But in CML, the immature one are more. So here NAP score is less. So basically we perform NAP score to differentiate the CML from leukemioid reaction. In CML, the NAP scores are less because here immature versions are there. And here in leukemioid reaction, the NAP scores are high because here the mature neutrophil will come in the blood. So I hope I explained you and you got it. And last one is others. Others may uric acid is high because hypermetabolism is there. So let's revise lab diagnosis quickly. So first, in the blood picture, the hemoglobin is less, the platelet is less, WBC are too high, more than 2 lakh. But all of them are immature, and you have to draw the diagram of the garden party. And you have to label everything. In the bone marrow, cellularity is high. Myeloid cells are predominant, but erythroid precursors and megakaryocyte precursors are less. You have to explain why. In the cytogenetics, you typically get Philadelphia Chromosome, that is 922 translocation, or ABL BCR. You have to draw the diagram here. In the cytochemistry, you will do the NAP score. NAP score differentiates CML from leukemia reaction. In CML, the NAP score is less because the immature versions are more. And in leukemia reaction, the NAP score or lab score is high because here the mature neutrophils are coming in the blood and others uric acid. That's it. So please learn the lab diagnosis. Coming on finally treatment. Treatment, initially we used to perform bone marrow transplant and we give the symptomatic treatment. If the patient have anemia, give blood transfusion. If the patient have thrombocytopenia, give the platelet transfusion likewise. So this is symptomatic treatment. But nowadays, we have a targeted therapy available for CML, the targeted therapy. The name of the drug is Imatinib. Imatinib is available in the form of the oral tablets are available. So Imatinib is the first targeted therapy discovered. So what does this Imatinib do? Imatinib causes the apoptosis of all those cells which is having ABL BCR mutation in them. So all the cells which is having ABL BCR fusion gene or hybrid gene, all that cells undergo apoptosis. So it is very after the treatment of Imatinib or targeted therapy, the prognosis of the patient is very good. So symptomatic treatment is available, targeted therapy is available, and bone marrow transplant is available. The three treatments are available. And coming on finally the prognosis. For prognosis of CML, two index are available, the Sokal index and Hasford index, given by two different scientists. So each of them, there are five criteria to decide the prognostic factor. So four of them are same. So age is a criteria in both of them. Older is the age, poorer is the prognosis. Platelet count, less is the platelet count, poorer is the prognosis. Spleen size, more is the splenomegaly, poorer is the prognosis. Circulating blast, more is the myeloblast percentage in both of them, poorer is the prognosis. But the fifth criteria is different. So here the fifth criteria is cytogenetic changes, and here the fifth criteria is basophil and eosinophil percentage. So learn the five criteria in both of them. That is the two type of index. We are done with CML. Can we revise it quickly? CML. Fill this table with me, please. So in the introduction, write down the definition of CML. What we have learned, the four criteria. Number one, patient have high WBC count. Okay. Number two, patient is having basophilia. Now you can understand. Number three, patient is having splenomegaly. And number four, patient is having Philadelphia Chromosome. If all four are present, the patient is having CML. Age, I told you, it usually occurs after 50 years in old age. So after 50 years. In the pathogenesis, I told you 922 translocation, that is ABL BCR translocation, taking place in myeloblast, promyelocyte, myelocyte, metamyelocyte, and band form. So these five cells are coming in the blood, the precursors one. In the classification, we are having three phases, I told you. So CAR, chronic phase, accelerated phase, and blast phase, CAB you can learn. So here the number of the blast is less than 10%, here 10 to 20%, here more than 20%. In the clinical features, I told you, anemia is there, thrombocytopenia is there, and infections are there. Anemia because RBCs are less, thrombocytopenia because platelet are less, bleeding disorders. But infections, although WBC are more, but they are immature. So susceptibility of infection is more. Now in the lab diagnosis, I told you, you have to write down blood picture, you have to write down the bone marrow picture, you have to write down cytogenetics, cytochemistry, and others. So in the blood picture, you have to write down RBCs are less, platelet is less, but WBC is high, garden party appearance. In the bone marrow, cellularity is high, myeloid is high, but erythroid and megakaryocyte are less. In the cytogenetics, you have to draw 922 translocation. And in the cytochemistry, a special stain is NAP or LAP. The NAP or LAP score in CML is less. But in leukemia reaction, it is high, and we can differentiate leukemia reaction from CML based on this. In the treatment part, I told you, in the treatment, three treatments are available. Symptomatic treatment, like blood transfusion, platelet transfusion, stem cell transplant, bone marrow stem cell transplant. And the most important is the targeted therapy known as Imatinib. So prognosis is very good with that. And prognosis, I told you two index, the Sokal index and Hasford index, you have to learn that. That's all about it. Don't forget to have a look on all the questions, especially the long question which are asked in the previous year of university exam from this topic. So have a look on the MCQs also. Thank you so much.